Okay, can you see my screen?
Yes, doctor.
Right, okay, so okay, so my lecture for today is thrombotic disease and embolism. Alright, okay, so this is the specific learning outcome for today's topic. Alright, from this lecture, you should be able to describe the risk factors, pathogenesis, the morphology, the clinical manifestation or the complication of arterial and venous thrombotic diseases. You should be able to define embolism and describe the risk factors, the etiology, pathogenesis, the morphology, which includes the gross and microscopic, clinical manifestation, complications of embolic diseases, which include primary embolism, systemic, fat, amniotic fluid, air, and also septic embolism. And the skill that you will acquire is to be able to identify the morphology, which include the gross and microscopic of pulmonary thromboembolism. Right? So, as an introduction, okay, the definition for thrombosis is the formation, development, or presence of a thrombus or thrombi. Thrombi meaning there is more than one thrombus, okay? I think you have already learned regarding thrombosis in the general module, okay? You were given a lecture by Dr. Umi Mohlisi, also from the Department of Pathology, and her lecture was on coagulation, fibrinolysis, and also thrombosis. So you can refer to her lecture. I think that time it was uploaded in the YouTube, so you can refer because it is related to this topic. All right. So as already explained by Dr. Umi, okay, for thrombosis, it relates to more than one component of the Virchow's triad. Okay, since triad, there is three main primary abnormalities to the formation of thrombus, which are the first one is the endothelial injury. Second is abnormal blood flow, whether it is stasis or turbulence, and also hypercoagulability, primary or secondary. Okay, so you either need only at least one of this component for the formation of thrombus. So what is thrombus? Alright, thrombus is a stationary blood clot along the wall of a blood vessel, and it frequently causing vascular obstruction. And why thrombus is important? Because it involved in the pathogenesis of several diseases, okay, such as myocardial infarction, cerebrovascular disease, peripheral arterial disease, deep vein thrombosis, and also primary embolism. Alright, so these are the main consequences of thrombus or thrombi formation. And in this, as you can see, it involves systemic involvement of thrombus, and in this module, okay, cardiovascular module, you will later have a lecture on myocardial infarction. For cerebrovascular disease, you will encounter this topic in your second year. Okay, now we go one by one. All right, so first we will discuss on ultrathrombosis. Okay, so thrombosis can occur throughout the body, all right, and the most common site of thrombus formation within the arterial system, there are a few. Okay, as you can see, the first one, it can occur in the left atrium. This will happen in patient who has atrial fibrillation, mitral stenosis, or a mitral valve prosthesis. Okay, another location is the left ventricle. Okay, this will occur in patient who has dilated cardiomyopathy, left ventricular aneurysm, or patient who develop acute myocardial infarction. Beside the heart chamber, it can also occur in the arteries. Okay, for example, in the carotid arteries at the site of carotid artery stenosis. Okay, another location is the abdominal aorta, and the arterial thrombosis will occur within an abdominal aortic aneurysm. Another part that will involve is the lower limb vasculature. Okay, it can occur either in the iliac, femoral, or even popliteal artery aneurysm. Okay, all right. So thrombosis, I have given you the definition, the formation of thrombus. All right. Sometimes arterial thrombosis or thromboembolism can be interchangeable. Why? Because most of the thrombus, okay, some part of it will detach and become emboli. So that's why you get the term thromboembolism. So when arterial thromboembolism occurs, it occurs when there is a piece of thrombus travel from its site of formation to a more distal part of the arterial circulation. So when there is occlusion of the artery system, okay, so when a thrombus detach, it goes to another place, we call it embolus, okay. It will cut off the oxygen supply to the intended tissue. Okay, when they are reduced in oxygen supply, then the tissue will develop ischemia. And if the ischemia is prolonged, okay, depend on several factors. Okay, you will have tissue infarction, all right? Okay, you already have this lecture in general module, okay, you can refer also to that. Okay, what will happen to the embolus or emboli? Okay, sometimes this emboli occur in the heart, and from the heart it can goes to any part of the arterial circulation. And sometimes the thrombus can arise in the artery, and from in any artery it can also go or embolize to the branches at a distal site. Okay. Alright, so the most commonly affected organs or tissue in arterial thrombosis or arterial thromboembolism is the brain, either the upper or lower limb, and also the intestine. Okay, so what will happen? Okay, the respective clinical consequences in the brain, patient can develop stroke or transient ischemic attack. Alright, and in the limb, they can develop acute ischemia of the limb or digit. And in the intestine, you can develop intestinal infarction. Alright, so if you see on the picture on the right, okay, as you can see, there is cardiac embolism and stroke. Alright, as you can see from the picture, okay, there is formation of thrombus within the heart chamber. In this case, the thrombus occur in the left atrium. Okay, then from the heart, okay, the thrombus detach and become an embolus. So it travels through the arterial system in the aorta, and it goes to the distal side, and in this case, all right, the embolus blocks the vessel that goes into the brain. Okay, so the area that is supplied by this artery, okay, become ischemia. All right, so as you can see, all right, the difference between the color of a normal tissue and the tissue that has been blocked by embolus. Okay, so that is the first example. All right, so now, okay, this is a second example. Okay, when there is arterial blockage in the lower leg. Okay, so as you can see, all right, this is an angiogram. Okay, an angiogram is an imaging, okay, whereby you check the vessel. So this is the right side, and then this is the left side. Okay, so in this case, all right, here is the abdominal aorta. Okay, this is a picture depicting what will happen. Okay, all right, so afterwards there will be like lecture on aneurysm. Okay, you will encounter this later. All right, so this is the abdominal aorta, and you can see there is clot. Okay, thrombus formation within the blood vessel. All right, so part of the thrombus is dislodged and become emboli, alright? And it travels into the lower extremities. Okay, as you can see, okay, the abdominal aorta is here, and then the emboli goes down to the distal arteries, which are smaller, and when they cannot go further, the emboli will dislodge. Okay, and as you can see, at this point of time, the patient will present with numbness and tingling of the lower left extremities. So this is the initial condition when patient develop ischemia. Alright, so subsequently, okay, when there is no perfusion or oxygen, okay, the food, okay, become necrotic. Okay, as you can see, the food became dark or black. Okay, there is no blood supply to the food, and when it happens, you have to amputate because the tissue is no more viable. Alright, this is what we call as below knee amputation. Okay, so you amputate below the knee level. So this one, alright, this is usually done by the orthopedic department. So that will happen when there is blockage or arterial thromboembolism in the lower limb. Okay, this is another example. Alright, this is what will happen when there is arterial thromboembolism in the superior mesenteric artery. Okay, so this is the blood vessel supply in the intestine. Alright, as you can see, they show you the colon. This is the transverse colon, right ascending colon. Okay, you will all learn this later in the GIT, gastrointestinal module in second year, but to show you, for example, right? So as you can see here, there is a thrombus in the supramesenteric artery. Okay, and you can see, okay, the one that is affected is below this. Alright, so the blood circulation below the thrombus is affected, and you can see because there is reduce in the blood flow, or if there's total occlusion. Okay, in this case there is total occlusion, and you can see that there is gangrenous colon here at the area. So you can see this is the normal pinkish color of the tissue, and this is the abnormal gray polyperfuse colon. Alright, it's also affected. Okay, part of here is the duodenum, part of the duodenum is polyperfuse. Okay, it also affect the jejunum. Okay, so you can see here the bowel became gangrene because there is no perfusion to the distal jejunum and ileum. Okay, so what will happen usually when there is gangrene, where you cannot save this one, you have to cut this colon, large and small bowel. Alright, and patient need to go for operation for this. Okay, so that is the example for arterial thrombosis. Okay, now we go to venous thrombosis. Okay, there are two types of venous thrombosis. It either can occur in the superficial vein or also in the deep vein. Okay, for superficial venous thrombi, okay, it occurs in the saphenous vein. When there is blockage by thrombi, it can cause local congestion, swelling, and pain and tenderness at the area. So this is local, depends on the site where the thrombus is lodged. And what will happen to the area, okay, the overlying skin can easily develop infection, and sometimes it can develop ulcer, what we call as varicose ulcer. However, the thrombus that form in the superficial or in the saphenous vein, it is rarely embolized, so usually stay there. It does not go anywhere. The more common venous thrombosis, what we call as deep vein thrombi or deep vein thrombosis. Okay, so sometimes we call it as DVT. it will involve one of the large leg veins. Okay, usually happen at or above the knee region. So usually the veins that involve are the popliteal, the femoral and iliac vein. So what will happen if there is thrombus formation in this area? Okay, it is important because the part of the thrombus can dislodge and will embolize to other location. Alright, so what are the risk factors for the development of venous thrombosis? Okay, you also have seen this before. So just a recap, it can be divided into inherited or acquired, okay? Or sometimes they call it as primary or secondary. So the inherited one is quite uncommon here in our population. Alright, but the most common cause for inherited thrombophilia is factor 5 leader mutation. Okay, followed by the other inherited causes, okay, the prothrombin mutation, protein S, protein C, and also antithrombin deficiency. Okay, I think Dr. Umi already have explained many of the risk factors. Okay, for those who cannot remember, you can always go back to the lecture. You can open the lecture in the YouTube channel. Okay, for the secondary, as you can see, there are multiple causes. Okay, all right, and in venous thrombosis, okay, among the important one is immobilization, okay, or extended bed rest. Okay, all right, what will happen? Okay, because of patient have prolonged bed rest or immobilization, there will be reduced in the milking action of the leg muscle. All right, thus there will be slow in the venous return. Okay, if you remember the Virchow's triad, okay, there are 3 main factors, but usually in venous thrombosis, okay, the abnormality in the blood flow, which is stasis, and also the hypercoagulable state will be the main contributing cause in the development of venous thrombosis. Okay, so there will be stasis. All right, so when there is stasis, there will be easier to develop thrombus. Okay, and then when there is thrombus, as I have mentioned, there will be complication for that. All right, so as you can see, there are a lot of causes. Okay, pregnancy, when you take oral contraceptive. All right, so for example, in pregnancy, there are many factors that can cause patient to be develop thrombosis. All right, beside, as you know, in pregnancy, the enlarging fetus and the uterus can produce stasis, okay, in the veins of the leg because they compress the vessels. All right, and usually when patient in the late state of pregnancy and when patient is in the postpartum period, usually they have hypercoagulable state. Okay, there are other causes. Okay, patient who have heart failure, congenital heart disease, antiphospholipid, patient who are older, they are more prone to develop venous thrombosis. Obesity, okay, this myoproliferative neoplasm, these are hematological disorders such as polycythemia vera and essential thrombocythemia. All these conditions can predispose patient to develop venous thrombosis. So there is a lot, okay? So now we go to the more specific disorder, deep venous thrombosis or DVT. Okay, all right, most DVT are asymptomatic, okay, they have no symptom, but if it presents, okay, they have local manifestation at the lower limb, okay, they have edema, okay, sometimes cyanosis, but usually they will come with erythema, okay, Alright, so when you do the physical examination, it is warm, it is tender, which is painful on palpation. Alright, patient can complain of pain. Alright, and sometimes you can see superficial vein dilation. Alright, okay, these are the local manifestation I mentioned. Patient are asymptomatic, local manifestation, and they can also present with the complication of DVT, which is pulmonary embolism. And I will explain on pulmonary embolism in the later part of the lecture. Okay, excuse me. Alright, so here you can see now, I'm going to show you how does, this is a picture explaining the formation of the vein thrombosis. Okay, you have learned regarding the blood flow in the vein. As you know, in the vein there is venous valve, so it will prevent blood from flowing backward. Okay, but because of this also it can create areas of slow moving circulation. All right, so when patients are predisposed, okay, if you go back to the risk factor, okay, when there is stasis, okay, all right, what will happen? Okay, there'll be fibrin accumulates in the area with stasis or slow moving blood vessel in the venous. Then this will trap the blood vessel. All right. Then there'll be continued development of thrombus. Okay, there'll be fibrin trapped in the with the blood cell combined with platelet. Okay, you have learned in the general module the formation of thrombus. Okay, what are the morphology, the gross, and also the microscopic. All right, so as you can see, the thrombus are become larger. Okay, so once it fill up the vein, there'll be much slower blood circulation, and because this it cause the swelling and pain. All right, so when part of the thrombus is break off or dislodged, this is what we call as an embolus. So embolus will go through the blood flow, blood circulation until it become lodged, until it can go no further and it will stay there. Okay, so this is the formation of thrombus. Okay, following the risk factor as I mentioned in the table earlier. Okay, patients are prone to develop this in the vein. Alright, so how do you diagnose deep vein thrombosis? Alright, so usually you will have clinical suspicion. What do I mean by clinical suspicion? Okay, when patient have presentation. Okay, as I mentioned, patients are usually asymptomatic. They have no sign and symptom. But the doctors will have clinical suspicion, meaning that they are suspicious that patient have DVT. Okay, when patient came with the painful or swollen limb. All right. Usually it is unilateral. Okay, unilateral. All right. There can be calf swelling or tenderness and sometimes pitting edema. All right. So when they suspect, all right, they will use this scoring system, what we call as well score. So there are several clinical features, okay, to determine whether patient have deep vein thrombosis or not. Okay, the clinical features are whether patient have active cancer, patient have distress factor of paralysis or immobilization. Okay, other risk factor of recently bedridden, where the patient have any major surgery. Alright, when patient have any of the presenting sign and symptom, alright, like this, tenderness, swelling, pitting edema, alright, where the patient have previous history. So when for each of these, they will give the patient 1 point. Okay. So if after assessing the patient, if the score is 2 points or more, it is likely to be DVT. But if the score is less than 1, minimum 1, it will be unlikely to have DVT. Okay, so as you can see, when you suspect clinically patient have DVT either by the symptom or patient come with pulmonary embolism presentation, so you do the scoring. So when the score is at least 2, it is likely to be DVT. But if his score is at least 1, it is unlikely. Okay, what you will do is, for the unlikely, okay, they will do the dimer test. This is to see why they do the dimer, because if it is negative, they can exclude the DVT, so they will not treat. But if the D-dimer is positive, they will proceed with scan. As you can see here, if the DVT is likely, they will start with the scan first. But for those that is unlikely, they start with the blood test first, which is the D-dimer. Okay, so usually you can diagnose DVT using the scan. Okay, the scan positive, then you start the treatment. But if the scan is negative, alright, you can repeat the other test. Okay, so no need to memorize this, only just I want you to know for the diagnosis of DVT, first you have to have clinical suspicion. How do you suspect? Patient present with the sign of symptom of DVT, or they come with the complication of pulmonary embolism. Okay, so for the diagnosis, they will use the dimer test to exclude, because if the D-dimer is negative, you can exclude DVT, and they also use imaging. Okay, alright, that's all. You don't have to memorize the other, but I think you will have lectures on anticoagulator under the pharmacology. Okay. So, alright, this is the imaging that will be used in diagnosing DVT. Okay, alright, here is the Doppler, alright, ultrasound. So you can see here, this is what we call color Doppler. They use this to check it at the femoral artery. Okay, so this is Doppler ultrasound. Okay, the second is venogram. Okay. Alright, so here you can see at the arrow here. Okay, there is thrombosis. And then you can even use CT scan, computed tomography of pulmonary angiography. Okay, of the pulmonary area. Okay, so these are the imaging that can be used in helping to diagnose deep vein thrombosis. Okay, mainly, okay, clinical suspicion. Alright, to exclude, you do the dimer and followed by imaging, which include either ultrasound, this is venogram, or even CT scan. Okay, so there's a syndrome in patient who develop the DVT, what we call is post-thrombotic syndrome. Okay, alright, so usually it occurs in 1/3 of the patient, around 30%, and usually it happens months or years after developing lower limb DVT. Okay, what happened is the venous thrombi persists, and when it persists, it destroys the valve, and this will cause the impaired venous return. So when this happens, it will lead to venous hypertension, and this will cause fluid accumulation in the extravascular space. Okay, please ignore this. Okay, what are the symptoms and signs? Okay, patient can come with pain, cramps, feeling of heaviness, itching, paresthesia, and usually it becomes worse at the end of the day and after standing for a long period of time. Okay, when you do physical examination, there'll be redness, induration, patchy hyperpigmentation, venous ectasia, and also sometimes you can develop venous ulceration in severe cases. Alright, so this is a picture of how does post-thrombotic syndrome occurs. Okay, this is the normal artery. Okay, as you can see, the valve within the vein, okay, will make the blood flow to the heart. Alright, so when you develop DVT, okay, there'll be clot formation. So when there is thrombus, okay, you can cause acute inflammation of the valve. Okay, if you compare the valve here and the valve here, okay, it's different, alright. Okay, this develop inflammation, okay, and when it is long-standing, months and years, it will cause permanent damage to the valve, alright. So, okay, the damaged valve will cause the blood to flow backwards. Okay, this will lead to chronic pain and swelling, okay, even though the DVT has been treated, and this is what we call as post-thrombotic syndrome. Okay, so but not many patients will develop, only one third of the patient. Alright, so this is another picture. Alright, this is what we call a venous ulcer. You can see the surrounding area, there is hyperpigmentation, okay. Alright, this can happen to patients who develop DVT. Okay, and how do we prevent DVT? Alright, so as you know, the risk factor are surgery, especially major surgery involving the pelvic bone or the long bone. So usually after a surgery, the doctor will suggest for early ambulation. Alright, they will ask patient to have therapeutic exercises, alright, to reduce the risk of forming thrombosis. Okay, as you know, extended bed rest and immobilization is the risk factor for developing venous thrombosis. Okay, they sometimes will ask you to use special stocking that will aid in the venous return. Okay, sometimes, okay, you can develop vein thrombosis when you are on long hours of flight. So that's why they ask you to use what we call as compression stocking. Alright, there are another method, what we call as intermittent pneumatic compression devices. Okay, this will a compression device, it will act as an artificial muscular contraction. So what it will do, it will propel the blood toward the heart against the pull of gravity. Okay, alright. So you can also exercise, or in certain condition you are started on anticoagulant therapy, okay, to reduce the risk of formation of blood clot, alright. And in certain cases, alright, they will put intravenous, inferior vena cava filter. Why they put this? Okay, if there is a thrombus formation, as you know, thrombus can dislodge and embolize to this other region. So when there is a filter here, even though there is a formation of embolus, okay, it will make sure that it does not go beyond the area of the filter. Okay, that is part on thrombosis. Now we go to embolism. Okay, this topic is interrelated. All right. So what is the definition of embolus? Okay, an embolus is a detached. Okay, detached intravascular, meaning it is within the vessel. It can be solid, liquid, or gaseous mass. Okay, so there are many types. The one that I have mentioned, the thrombus, is an intravascular solid mass that is carried by the blood from its point of origin to a distant site, where it often causes through dysfunction and infarction. So majority of the emboli are dislodged thrombi, so that's why the term is sometimes called as thromboembolism. Okay. Other rare type of emboli are composed by, can be either fat droplets, air or nitrogen bubble, atherosclerotic debris, or what we call as cholesterol emboli, tumor fragments, bone marrow tissue, and also amniotic fluid. Okay, now I'll go to the next topic. Okay, pulmonary embolism. Okay, this is important. As I mentioned, it can be a complication of deep vein thrombosis. Okay, it is the most common form of thromboembolic disease, and 95% originates from deep vein thrombosis. So the risk factors are similar to DVT, especially prolonged bed rest, especially with immobilization of the leg, surgery, especially involving the orthopedic surgery on the knee or hip, patient who has severe trauma, including burns and multiple fractures, patient with congestive heart failure, in women, period around parturition is meaning delivery, I have mentioned when the period is near the delivery, patient, usually a woman will have hypercoagulability state, and the use of oral contraceptive pill with high oxygen content, this patient with disseminated cancer and primary disorder of hypercoagulability. So I just mentioned some of the ones that are already listed in the table before, right? Okay, so what are the mechanism of pulmonary embolism? Alright, I have already explained this. First, you must have formation of deep vein thrombosis, diastasis, trapping of the blood cell with the fibrin and platelets, then there be formation of thrombus which getting bigger, and when there is a dislodged thrombi, we call it embolus. It travels through the bloodstream up to the heart, from here, as you can see, going from near the lower limb, it goes to the heart, alright, as you can see, it enters the circulation and it goes into the pulmonary arteries, here you can see cut open section, this is what we call as saddle embolus, and it can goes within the lung tissue, and also become small embolus at the pulmonary vessels, alright. So this is a gross picture. Morphology depends on the size of the embolus. Usually if there's a large, it will embed in the main pulmonary artery or its major branches, So when it lodge, extending across, this is the bifurcation of the pulmonary artery, we call it as saddle embolus, So this large one, they stay in the main vessels, But for smaller emboli, either medium size or small size, they will go to the pulmonary arteries and lodge into the tissue. Alright, you have learned this in the general module. So this is the lung tissue. This is what happens when you develop infarct. It is wedge shape. Alright, the base is at the pleural surface and the apex pointing towards the highest of the lung. This is what we call hemorrhagic or red infarct. Please remember, red infarct, why the lung have red infarct? Because they have dual circulation. Alright, so there are other organs also which have red infarct. And the histology is, if you see under microscope, it will have ischemic coagulative necrosis. So this lecture is related to the lecture on ischemia infarction, and also the initial lecture is related to thrombosis, lecture by Dr. Umi. So what are the clinical consequences or outcome for pulmonary embolism? Okay, so actually it depends on the size of the emboli, alright? In majority of cases, 60% to 80%, patient don't have symptom. What we call is asymptomatic because the size of embolus is small. Okay, so the viability of the affected lung is sustained because the lung have dual circulation, right? So what will happen to the emboli? Okay, you have learned the fate or outcome of thrombus. Okay, there be resolution or dissolution of the thrombus. Okay, so there don't have the dissolution of thrombus of emboli. So there is no more thrombus because of the action of the fibrinolysis. All right. That is in majority of cases. Okay, in 10 to 15% of the cases, there can be obstruction of the small to medium primary branches. Okay, and in patient who have circulatory insufficiency, okay, the patient can develop primary infarction. Okay, that is the example I show you in the morphology previously. And in this type of patient, okay, they will present with shortness of breath or dyspnea. Alright. Okay, in small percentage of patient, about 5%, okay, they can have sudden death due to massive pulmonary embolism. Okay, why do they have this complication? Because, alright, more than 60% of the total pulmonary vasculation is obstructed. Okay, it is obstructed either by a large embolus, one big embolus, or multiple simultaneously small emboli. Okay, multiple, there's a lot. Simultaneous is at the same time. Okay, that's why you develop sudden death. Okay, beside this, alright, you can develop acute right heart failure, and patient can collapse. Okay, usually affect the heart cardiovascular collapse or shock. That's only in a small percentage, about 5%. Okay, and in less than 3%, when there is recurrent showers of emboli, so there is multiple emboli but is multiple time recurrent, this will lead to pulmonary hypertension, chronic right side heart failure, and also patient can have pulmonary vascular sclerosis, and usually patient will have progressive worsening dyspnea or shortness of breath. The risk for recurrence of pulmonary embolism is high, okay, whereby 30% of patients who have the first episode of pulmonary embolism, they will develop second episode of pulmonary embolism. Is on pulmonary embolism. Okay, now we go to systemic thromboembolism. Okay, alright, as I mentioned, this is because thromboembolism because the emboli are mainly due to dislodged thrombi. Why it is systemic? Because it arises in the artery system. Okay, whether the heart or the large arteries, and the main cause are from the intracardiac mural thrombi, which is 80% of the systemic thromboembolism. Okay, so this is the main location where the systemic thromboembolism arises. Okay, the other location are from the arteriomatous plaque with thrombus, from valve vegetation. Okay, in patients who have atrial fibrillation, that can develop atrial thrombus. Okay, patients who have old myocardial infarction, and also in patients who have recent myocardial infarct. Okay, rarely there'll be paradoxical embolus. What does it mean by paradoxical embolus? Meaning that the emboli comes from the venous system. Okay, in systemic thromboembolism, it is from the arterial, but they can be not it's rare, but we call it as paradoxical embolus because the embolus or the dislodged thrombi come from the venous circulation. Okay, so if the embolus occur in the heart, okay, it can go to the systemic circulation. It can cause arterial circulation, distal ischemia, and infarction. And the main one, okay, that can be affected, it can go to the brain, causing stroke or neurological deficit. Okay, it can cause renal or splenic infarct. Okay, it can go to the intestine. Okay, causing intestinal infarction, and also it goes to the limb. As you can see, these are related to the previous topic that I've discussed on arterial thrombosis. Okay, so it has similar outcome as you can see here. Okay, there is a lot, multiple area in the heart, okay, where you can develop thrombus. Either here is an example of atheromatous plaque with thrombus. Okay, this you will learn later in the next topic. It can occur in the atrium, all right, when there is thrombus on the valve, we call it vegetation. Okay, all right, there can be also thrombus at the area of either old or recent infarct, and when the thrombus dislodged, it goes to the systemic circulation and it can go to all these organs and causing pathology. All right. Okay, so that is on systemic. Okay, there's one type of embolism, what we call as fat embolism. Okay, it happens when there is soft tissue crush injury or rupture of marrow vascular sinusoids, usually long term. Okay, usually it occurs due to long bone fracture. Okay, usually it happen, fat embolism, it will happen usually in multiple severe fracture. Okay, so what will happen is when there is soft tissue crush injury or long bone fracture, this will release microscopic fat globules in the circulation, meaning that you cannot see it with your eyes. Usually microscopic meaning is small. Okay, it occurs in severe skeletal injury. Okay, you must have a massive injury, multiple injury, then this condition can occur, but usually it is asymptomatic. Okay, all right, only less than 10% show any clinical findings. Right, so how does fat embolism develop? Okay, okay, usually is fracture. Okay, you can see this is the bone. Okay, and the blood supply, in this case it gives the example of the tibia bone. Okay, so you can see here are the fat and marrow tissue. Okay, there is marrow within the bone. Okay, so when there is fracture, all right, okay, the surrounding fat deposit will go into the vein opening in the ruptured blood vessel. Okay, you can see there is fracture. When there is fracture, the blood vessel will rupture. So what will happen? The fat and the marrow will go inside to the opening. And what will happen? It will move, okay, through the femoral brain and into the inferior vena cava, and it can enter the heart or the lung. Okay, all right. So there's one syndrome here, what we call as fat embolism syndrome. Okay, only in small occur in small percentage of patient. Okay, patient will complain of pulmonary insufficiency. There is neurologic symptom. Okay, when you check the blood result, the full blood count, you can see that the hemoglobin level is low, anemia, okay, and the platelet count is also low, thrombocytopenia, and when you examine the patient, you see diffuse petechial rashes. Okay, all these are usually appear 1 or 2 days after the injury. Okay, the pathogenesis involve mechanical obstruction and biochemical injury. Why? Okay, why does this patient have this sign and symptom? Okay, affecting the lung and the neurology. Because there is fat microemboli which occlude the pulmonary and cerebral microvasculature, and this will directly trigger the platelet aggregation. Okay, so this is what we call as fat embolism. It is only in a small percentage of patient, and the sign and symptom usually will affect the lung and the central nervous system. Okay, patient present with diffuse petechiae, and when we do the blood test, there is low level of hemoglobin and platelet. Okay, another type of embolism is what we call as amniotic fluid embolism. Okay, this is a complication of labor and it occurs immediately postpartum. Okay, postpartum meaning after delivery. It is rare. Okay, only 1 in 40,000, but the mortality rate is 80%. So there is in 80% chances of developing patient died. So the onset, it is characterized by sudden severe dyspnea or shortness of breath. Patient with sinus, patient develop shock, and it is followed by neurological impairment. Okay, patient can complain of headache, patient can develop seizures, and even develop coma. Okay, the underlying cause is entry of an amniotic fluid and its content into the maternal circulation via tear in the placental membrane, and or if there is uterine vein rupture. Okay, so when there is tear in the placenta plus or minus the uterine vein rupture, okay, the amniotic fluid and its content can goes into the circulation and cause amniotic fluid embolism. Alright, so this a picture. Alright, so this is the uterus. Okay, this is the placenta. Alright, so after delivery, as I mentioned, it is immediately postpartum after delivery. Okay, the baby have gone out. Okay, there can be some tear from the vein, or okay, there is after the detachment of placenta, okay, the amniotic fluid and fetal tissue will go into the maternal. So it goes into the mother circulation. Alright, so goes to the heart and goes to the lung, okay, and even goes to the brain. So that's why patient have lung or pulmonary and also neurological manifestation. So when you do autopsy, okay, alright, this is a pulmonary arteriole. This is the lung tissue, okay, under high power. Okay, if you can see, this is the one pulmonary arteriole, okay, small blood vessel. Second, two pulmonary, and this is within the lumen. Within the lumen, as you can see, if there is lumen, it should be empty, but here it is occluded with fetal tissue. This is squamous cell. Squamous cell, okay, the skin of the fetus. Alright, and you can see kalau lung, maybe you have not seen the lung tissue, you should have A spaces. But here you can see it is congested with, this is all the red cell, okay. In the lung tissue, you should have empty because lung should have air. But here it is edematous and congested with red blood cell. Alright, that is amniotic fluid. Okay, another one is air embolism. Okay, what happened in air embolism? Okay, gas bubble. Alright, within the circulation, they can combine to form frothy masses. So when they form large mass, it can obstruct the vascular flow and cause distal ischemia. Okay, alright. Example, maybe a small volume of air trapped during coronary artery bypass or during the neurosurgery operation whereby patient is in sitting position. Okay, they can introduce a small volume of air into the cerebral circulation, and then this can occlude either the cerebral or the heart, okay, coronary circulation, and it will cause fatal consequences. Okay, that is if it happens in coronary or cerebral, they need very small volume of air that can cause the dire consequences. But to have any clinical effect in the pulmonary circulation, usually the volume of air is more than 100 cc. Okay, this can occur if is introduced during obstetric or laparoscopic procedures lah, or when patients sometimes develop chest wall injury. So air can be introduced into the pulmonary or lung circulation by this way. Okay, with regards to air embolism, there's one what we call as decompression sickness. It is a particular form of gas embolism. Okay, alright, so usually it is caused by sudden change in atmospheric pressure. Okay, individual at risk is usually scuba or deep sea divers and underwater construction workers, also person who works in unpressurized aircraft in rapid ascent, okay, going up very quickly. So for example, in scuba or deep sea divers, alright, so when they go deep into the sea, okay, the air is breathed at high pressure. Alright, there'll be increased amount of gas, usually particularly nitrogen, that will dissolve in the blood and tissue. So let's say when during the scuba diving, okay, suddenly the diver have noticed that he has very low amount of oxygen, so he will ascend quickly, okay, because of the problem with the oxygen. But what will happen here? Okay, when he ascend too rapidly, alright, the dissolved, okay, gases will, in this case nitrogen, will expand in the tissue, alright, and bubbles out. Okay, initially it dissolved, but now it form bubbles, okay, and form bubbles in the vasculature, and this will form gas, okay, and when there's a lot, it can cause tissue ischemia. Alright, okay, so they can develop bands. This is when patient develop painful condition due to rapid formation of gas bubble within the skeletal muscle and also the supporting tissue and joint, and what we call as chokes when the gas bubble develop in the lung pulmonary circulation, which cause respiratory distress. So the treatment is usually place the affected person in a high pressure chamber because we want to force the gas form back into the solution form. Alright, when it's chronic, we call it Kaizen disease. This happens when there is recurrent or persistent gas emboli in the skeletal system. And this will lead to multiple foci of ischemic necrosis, and this usually occur in the femoral head, tibia, and also the humerus. These are the common locations. Okay, there can be also tumor embolism. Alright, This is usually, they are mainly small, alright. Okay, you can see the tumor, the small tumor emboli within the blood vessel. They don't have any they don't cause immediate physical problem, but usually we see this tumor embolism, okay, when the tumor has metastasized throughout the body, alright. So it is actually a route of tumor dissemination. Okay, last but not least, okay, I'm going to mention regarding foreign body embolism. Okay, it often occurs with intravenous drug abuse. There can be presence of talc or magnesium tricyclate in the intravenous mixture. Okay, this will elicit a granulomatous response in the organ in which the foreign body lodge. Alright, that's all. Okay, thank you everyone. I will unshare the screen. Okay, do you have any questions with regards of the topic?
Assalamualaikum, Doctor.
Yes.
I got a question regarding the arterial blockage of the lower limb.
Huh?
Can it be treated early with early treatment, or does it rapidly turn into necrosis?
Sorry, can you repeat your question again?
Regarding the arterial blockage of the lower limb, it can be treated with early treatment, or does it rapidly turn into necrosis?
Oh no, it won't. Usually necrosis to usually chronic. Okay, usually if you remember the picture, okay, usually patient will come with like numbness, okay, loss of sensation. So usually by that time they will go to see the doctor lah, alright. And then the doctor usually they will investigate what is the cause. Okay, they usually a lot of causes that can cause lower limb abnormality. So they will usually treat the one that is usually amputated to, if you remember, or you have counter, is patient with have concurrent diabetes mellitus. Have you seen before? So usually patient, okay, you will learn this later in the endocrine module in year 2. Okay, the complication of diabetes is, one of them is macro and microvascular complication. When there is microvascular complication, meaning they have problem with the blood circulation, and because of the diabetes, they have poor perfusion and poor wound healing. Okay, so if they don't control their sugar level, the diabetes, if it's not well controlled, they can have the problem with the distal limb. All right. Usually, what will happen in patient with diabetes? Sometimes, if you have seen or you have any family members, or if you have encountered, they have neuropathy whereby they cannot feel. So let's say if they have any injury, all right, they cannot feel the pain. So usually, if they have blisters or infection, it will become severe. It's not well treated, and sometimes this will lead to the gangrene of the toes, of the distal toes and all the digits, and that's why sometimes patient will have to amputate because they develop gangrene. So this is usually seen it is commonly seen in diabetic patient, unless you have other type of diseases related to artery, then otherwise it is rare. But the common one that you can see which patient develop necrosis is in patient with diabetes. And when you work later in hospital, this is the type that you will encounter, and these are the type of patient that need to do debridement, and sometimes they do below knee amputation and even below hip amputation because of they have problem with the circulation. Does that answer your question?
Yes, Doctor. Thank you.
Alright. Okay. Any other question? Ada apa-apa soalan lain?
Doctor, I have a question.
Yes.
I have two questions actually.
Okay.
First one, can hypothermia cause thrombosis or embolism? Because I have seen cases where hypothermia causes amputation of the limbs.
Okay. I don't think the one that usually related with thrombosis is burn. So far, I have not encountered, but hypothermia, they have to amputate. Maybe the mechanism is different from. I think it's different from thrombosis. The mechanism of development of thrombosis. They have to be, I think, something to do with the circulation. And then that's why they have to amputate. Kan biasanya macam patient yang I think yang macam frostbite kan, yang macam let's say they are in tempat yang sejuk and then they develop frostbite. I think because the circulation tu tak bagus, because they slow the circulation in a way and then they develop ischemia lah. Okay. Alright, but I don't think it is due to thrombosis lah. Thrombosis, if you remember the definition, okay, there is formation of blood clot. But let's say if it is since I have not encountered, but if you have any reference with regards to the hypothermia causing thrombosis, you are welcome to email to me, so at least I will be updated on this matter. Okay. Any other question?
And my second question, doctor.
Mm-hmm.
You mentioned that there was intestine that had gangrene. And I thought, how can the patient survive if we were to remove the gangrenous intestine?
Oh, boleh. The patient can survive, cumanya okay, nanti when you go to the GI tract, okay, actually if you learn, there are small and large intestine, and actually kalau you go, it's quite long, okay, so usually when there is gangrene, you cut a portion of the intestine, tapi patient will have problems because according to the location tu kan, usually dia ada dia punya macam function kan, nanti you belajar untuk for the nutrient absorption, so nanti dia ada complication. But then sometimes kalau let's say they potong the near to the rectum kan, so maknanya you cannot defecate atau post motion normally, nanti you kena pasang bag lah for the feces to keluar. Do you understand tak? So it's not patient cannot survive, they can survive but they will develop complication. Kebiasaannya kita tak adalah potong the whole length of the intestine. Usually sebab nanti you belajar, the intestine tu dia ada multiple blood supply. So unless kalau jarang lah, usually ada macam when one artery or venous system are blocked, dia akan hanya affect certain part atau portion of the intestine. So the other part tu okay, tapi patient will have complication. Maybe dia kena dapat special makanan ke apa benda, ataupun dia have difficulty, dia tak boleh, ada certain food yang dia tak boleh ambil ke apa. So they will have complication. But patient will not die lah kalau kita buang tu. Sebab kalau kita tak buang, patient will definitely die. Sebab kalau gangrene kan dia dah busuk, nanti you can get and then when dia dah busuk tu, dia can dapat peritonitis and go to organ, nanti patient will die because of the complication. So to save the patient, that's why kita cut off the gangrenous part of the intestine.
Understood, doctor. Thank you.
Alright. Okay, do you have any other questions? Ada apa-apa soalan lain? Okay, if there is no question, thank you everyone. Okay. Otherwise, if you don't have any question, you can always email to me, or you can contact me through the Microsoft team with regards to the lecture. Okay, thank you very much everyone, and it's not too late to wish you Selamat Hari Raya. Okay, thank you.
Thank you, doctor. Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Hari Raya.
Thank you, doctor.
Thank you, doctor. Thank you, doctor.